Good morning, everyone. This is Amy. It is a extreme pleasure and honor to be able to start off our grand rounds this morning. It's our special grand rounds from the research division, where they invite a particularly renowned and respected leader in our field. And so I'm going to turn it over to Dr. David Clark. And before I do so, I just want to mention that we do have a slide with the CME credit information, the phone number to text to, and then the actual number, which is listed right here. And that will also be posted in the chat as well if we don't get it right now. I'm just now going to turn over to Dr. Clark, who will introduce our speaker for today. Thanks.
Well, I'd like to thank everyone very much for tuning in this morning. This morning would normally be the grand rounds followed by a day of visiting for a special research day of celebration, entire day, and finish off with a dinner meeting where people would get to display posters and would have a few additional presentations. But the misbehaviors of a certain virus we all know have prevented us from being able to do our annual research celebration. That had to be canceled. But that didn't mean that we didn't want to at least do the grand rounds part of this. We normally invite a speaker to do this, the criteria for which are the person should be a preeminent anesthesiologist with a history of scientific successes, with clinical accomplishments, and a person with a history of having many other leadership roles in the field. And I could not be more delighted this morning than to be able to tell you our guest will be Dr. Deborah Culley. Dr. Culley attended University of Washington medical school in beautiful Seattle that I know very well, then moved to the East Coast where she has made her career. She did her anesthesiology residency in the Harvard system and Mass General Hospital. She was appointed assistant professor in 1997 and has been in the Harvard system clinically at the Brigham and Women's Hospital since that time. Currently, she is an associate professor who occupies a distinguished chair in the department and is executive vice chair for the department. She is on numerous departmental and hospital committees and also is very involved in both the ASA, where she's the chair of the Academic Anesthesiology Committee, and the ABA, where she is currently president. She's had extensive involvement in residency education and is a mover and shaker in academic anesthesiology. She is certainly one of the true champions of academic anesthesiology. She also serves as an executive editor on the board of the journal Anesthesiology. In terms of research, she's had a very extensive research career, focused most recently on mechanisms of delirium and postoperative decline, which she will be lecturing on today. She's an exemplary translational researcher and has conducted numerous laboratory and clinical studies in the area. For these, she has had long-term support from the NIH and other agencies. She's prolific in her speaking engagements, her peer-reviewed publications, book chapters, and the mentorship of trainees. And with that, I'm going to turn things over to Dr. Culley.
Well, thanks, David. I'd like to thank everybody for inviting me here today. I, too, would prefer to be able to be there and share with you your very special day. And unfortunately, that little virus has decided that I'm going to do this from home. So I hope that from home, I can share with you a little bit of information about one of my favorite topics in the world, that topic being postoperative delirium. I'm going to limit most of this to the clinical aspects of it, even though I've done extensive research on the basic science aspects, just because it's a little bit more interesting for everyone else to see. So I'm hoping that you can all see my slides currently. I have to declare a couple of conflicts. The first three are the ones that I enjoy a lot because they allow me to do the research that we're doing, and that's funding through the NIH. And as previously mentioned, I am a director for the American Board of Anesthesiology and an executive editor for the journal Anesthesiology, two things that are equally important in my career. There are a number of objectives that I had sent in, and they're pretty simple because I'd really like for things to be functionally, clinically. In other words, the types of things that you as a clinician can incorporate into your practice day to day. And one of those things is baseline cognitive screening. We'll talk a little bit about that and whether or not it can be a predictor of postoperative delirium. I'm also going to talk a little bit about frailty and how it's associated with postoperative delirium. And then hopefully by the end of this, you'll also be able to screen your patients for delirium postoperatively and recognize that without utilizing any of these screening tools, it makes it very difficult to be able to detect those vulnerable patients. We all know that the US population is aging. I'll show you a picture at the end of this slide set of my grandfather, who happens to be 104 years old. But when he was born in the 1920s, there was a very small prevalence of individuals who lived to be 75, nevertheless those that are 85 and above. But when you look where we are today, we've got roughly 25 million individuals that are over the age of 75 years of age, an age group that's particularly vulnerable to the development of postoperative delirium. When we think about postoperative complications in older surgical patients after non-elective surgery, we always think about things like heart attacks, myocardial infarctions, congestive heart failure, PEs, and aspiration pneumonia. And what you can see here is, yeah, they happen in individuals that are in their 50s. They also happen with a higher prevalence to those in their 80s. But what's most interesting about this from my perspective is that we always think about the heart, the lungs, the kidney, and the liver, but rarely do we really think about the brain. Despite the fact that postoperative neurocognitive disorders in the form of both delirium and postoperative cognitive dysfunction are the most common abnormalities that we'll see in our aging patient population, suggesting that we really do need to start thinking about whether or not our patients are at high risk for these morbidities. Interestingly, we don't screen for things that would tell us whether or not a patient has delirium or postoperative cognitive dysfunction risks. Rather, we screen for things like do they have cardiovascular disease, pulmonary disease, renal disease, or hepatic. And I think it's time for us to start looking at their neurologic function. As you know, there are a number of risk factors for delirium, age being among the preeminent or most well-known patient factor. There are surgical types that have an increased risk, in particular emergency surgeries, cardiac surgery, and major vascular and thoracic. There are medical reasons such as fever, electrolyte abnormalities, and frailty. Physiologically, if you have a low oxygen saturation or low albumin, you have a higher risk, probably because you're frail, of developing delirium. And then there are some meds that we have used traditionally that are associated with delirium, and we want to try to avoid them. When we talk about advanced age, not all aged individuals are the same. We all know about that aged individual who's kind of hunched over, can barely walk across the street. That would kind of be depicted by this little image here. But there are plenty of older individuals who are very different from that. They either have very high levels of education, are very cognitively engaged, or very physically engaged. So just being old is not enough. There have got to be other things likely that are going on to increase your risk of postoperative neurocognitive disorders. What we know now is that there are a lot of people living in the community that are thought to be cognitively intact that actually have cognitive impairment. This is a study performed on a large number of individuals who did not have known cognitive impairment. So they didn't have Alzheimer's, they didn't have vascular dementia, they didn't have mild cognitive impairment. And using these screening tools, what they found was roughly that 16% of community dwelling elders have some degree of cognitive impairment. If you're between the ages of 60 and 64, it approaches 14%, but it's almost 25% by the time you get to 75 to 79, and it's even higher in those individuals 80 years of age and older. In other words, we probably have these people showing up in our busy pre-admission testing centers with some baseline cognitive impairment. So there was a study that was published in 2011 by Liz Everand, who's from Australia, and what she did, she's a neuropsychologist, she did very careful neuropsychometric testing in patients that were thought to be cognitively intact prior to an elective total hip replacement. And what she found was very interesting. 13% of them had pre-MCI, 16% of them had amnestic MCI. In other words, roughly 30% of that thought to have those individuals that were thought to have healthy cognition actually had some degree of cognitive impairment. Now, you and I both know that we're not going to be able to spend an hour and a half looking at cognition in our older surgical patients, but it doesn't mean that it's not important. So prior to this point in time, I had primarily been looking at the effects of anesthesia on the cognitive performance of old animals and looking at the molecular mechanisms that might be involved with the changes. At that point in time, I had zero interest in starting clinical studies, so we put out a call for action. Come on, guys, let's start doing this. Let's study it. Let's see whether or not we can evaluate patients who have impaired cognition and whether or not it's associated with adverse outcomes. But the call was largely left empty. So in 2014, we started a study where we looked at cognitive screening in older elective surgical patients. It didn't matter what type of surgery they had, and we weren't looking for outcomes, but rather, is it something we can do? And it probably seems odd. Why would you look to see whether or not it was something that you could do? Of course you can. Well, I had probably spoken to 15 or 20 neuropsychologists and would ask them, what are the best screening tools for us to use? What can we do to do this briefly? And they would all say, nope, you can't use a brief screening tool. It's got to be in a quiet room, and you've got to spend an hour and a half. But that just wasn't feasible in a busy pre-admission testing center. So we needed to think outside the box. And our outside the box thinking was that, yes, it is a stressful environment having your pre-admission testing center visit, but that's not nearly as stressful as it's going to be during your post-operative evaluation. So we went ahead and did it. When we did this, we used a mini cog and a clock in the box test. And the reason for choosing those two tests initially is that almost all of the neuropsychologists felt that some sort of clock drawing was imperative because it measured executive function. So we did this in 199 patients and found that roughly 22% of those individuals were impaired depending upon the testing that was utilized. And what you will notice is that those individuals who are under the age of 75, no surprise, have a lower level of cognitive impairment at baseline when compared to those that are over age 75. But there was a very high prevalence of cognitive impairment overall, over 20%. The interesting thing is if you don't look, you won't find it. And that's not just because we're sitting in a busy pre-admission testing center. It's because most clinicians cannot identify cognitive impairment without a thorough, comprehensive evaluation. We asked our nurse practitioners who had helped us implement preoperative cognitive screening into our busy pre-admission testing center to identify patients that they had taken care of but did not administer the test to whether or not they were cognitively intact. And interestingly enough, of the 22% of patients that had a mini-cog less than or equal to 2, there was no correlation between the subjective evaluation by the nurse practitioners and the test scores. It's not because our nurse practitioners aren't absolutely wonderful and good at what they do. They are, but the data would say that nurses and physicians alike are very poor at identifying cognitive impairment through a normal evaluation. We also wanted to look at what older people thought about having cognitive screening, because if they didn't like it or they felt uncomfortable with it, we might want to think about what we're doing. And we asked them whether or not they thought it should be performed before a surgical procedure, and 79% of them said yes. If the memory test predicted adverse outcomes, then they would be more likely to want to have it done. And if they had a memory impairment, they wanted to know about it. But interestingly enough, this last question, if the memory test suggested probable cognitive impairment, would you want to be referred to a memory specialist, was answered yes only 82% of the time. I found that quite interesting. If you knew you had cognitive impairment, why wouldn't you want to go and identify what it was so that you could modify your lifestyle around it? So I asked what was at that point in time my 99-year-old grandfather, who's my resident geriatric patient, why it is that they wouldn't want to know. And his response to me was simple: honey, and yes, he's probably the only person in the world that can call me honey, but he is my grandfather. I know I'm losing my marbles, but I don't want you to know. And I thought that's another thing that's really important to recognize, is that older patients are very sensitive to the idea that they have any limitations, and they really don't want others to know. With that first study, we didn't look at whether or not it was associated with outcomes. So we subsequently performed a prospective study where we looked at mini-cog scores in our older surgical patient population. In particular, this was limited to those that were having hip or knee replacement procedures, so that the type of procedures were the same. And we administered the mini-cog, and I'll show you how you can do that in just a minute. And if you had a mini-cog of 0 to 2, that was a positive screen for probable cognitive impairment, whereas that greater than or equal to 3 was a negative screen. 24% of our patients had preoperative cognitive impairment at baseline. Among those, 67% were discharged to a place other than home, something that's very important to our older surgical patients. In particular, they want to go home. They do not want to be institutionalized, so it's a patient-centered outcome. 21% of them developed postoperative delirium compared with 7% for those without cognitive impairment, and their hospital length of stay was more than a day longer than those who did not have cognitive impairment. In other words, preoperative cognitive screening can be performed in a busy pre-admission testing center, and it's associated with adverse outcomes. We're not the only people who've identified that some form of cognitive assessment is a predictor of postoperative delirium. This was a study that was performed in 2015 by Jackie Leung from UCSF, and what she did was an animal fluency test. That is a very simple test where you literally ask somebody to name as many animals as they can in 1 minute. And then for those individuals who can name 16 or fewer animals, the thought is that they have cognitive impairment. In Jackie's group, they drew that number at 14, but 16 is more traditionally accepted. I hope that they screen me with that test when I get older, because my daughter-in-law is a zookeeper. And so I would just take my walk around the zoo and name all the animals that I can remember being there, and will probably pass way out into my later lifetime. But what was interesting, as you can see here, the red bars are those that did not have delirium, the blue bars are those that had delirium, and those that had a lower verbal fluency score were more likely to develop postoperative delirium, another screening test that can be utilized. I'm not trying to sell you on any particular cognitive screening test, so I'm throwing a third one in here. This one involved a retrospective study of 82 patients. They used something called the slums, where a normal cognition score between 27 and 30 points is normal. Between 21 and 26 is mild cognitive impairment, and less than 20 is frank severe cognitive impairment. And what you can see here is that for those individuals who had a normal score, the prevalence of delirium was about 8%, but it approached 20% in those with cognitive impairment. I think the important thing here is not trying to find the perfect screen, although some we may eventually find to be better than others. At the current point in time, we don't know what that cognitive screening tool might be, so you need to choose one. Verbal fluency is incredibly easy. We've used it now in our lab and have found it to be incredibly effective, as is the mini-CAG. But the big point is really here, and that's that for best practices for postoperative brain health in our older surgical patients, baseline cognition should be objectively evaluated if you're 65 years of age or older, or if you have any risk for pre-existing cognitive impairment. And that's been stated not only in this best practices or guideline, there are a number of guidelines from the geriatric literature, for the surgical literature, and now in the anesthesia literature, suggesting that we need to preoperatively cognitively screen our older patients. I had mentioned that one of the objectives was to show you that you too can administer and score the mini-COG, but I also want to share with you some of the limitations to a test such as this. For the mini-COG, you ask the patient to remember 3 unrelated words. So as you can see right here, banana, sunrise, and chair are unrelated. You have them verify that they remember the words by saying them back to you, and then you ask them to draw a clock and set the clock to 10 minutes after 11. It works very effectively. For each word that they can remember after they've drawn the clock, they get 1 point. And for the clock drawing, they can get either a 0 or a 2. Those individuals with cognitive impairment are thought to have a mini-COG score of less than or equal to 2. And if you really want to learn how to do this, you can go to minicog.com, where there are great instructions as well as forms that you can utilize to fill it out. I had mentioned that there are some problems potentially with this. This version number 1 used to have apple, watch, and penny as the 3 words that were there. 3 unrelated words, except in the middle of a study, my research assistant says, "Deb, I think we have a problem." And this is the value of having very intelligent research assistants. Apple Watch is now 1 word, and they're all getting it. So whenever you're trying something new, you have to remember that society changes, the world changes, just like we're in a COVID pandemic now and I can't be here. The mini-COG, using the words apple, watch, and penny, were no longer valid. It was a very good learning experience for me. The clocks that you'll see when you're doing this are bizarre, and I never thought that I could see a clock drawn like this until my father, towards the end of his life, drew a clock almost identical to this one right here, and you realize, yes, these are the signs of individuals who are struggling with regards to their cognitive performance. So clock drawing is very predictive of whether or not you're going to have a cognitive deficit. It's not just scientists that think that having a cognitive test before surgery is important. This has really hit the mainstream news. This was published in 2016. The concept that a mental test before surgery may be able to predict outcomes in older patients became very widely read by a number of individuals, and at least I received a couple of calls about it. In addition to cognitive screening, there are other things that we might want to take into consideration. One of those things is another geriatric syndrome known as frailty. And there are a number of different types of frailty, and one of the components can often be cognition. So just keep back in the back of your mind that cognition can be a part of frailty. There are these biologically driven causes of frailty. We all recognize them. Have you lost your muscle mass? Are you physically active? Have you lost weight that you didn't intend to lose? Can you stand up and walk quickly? What's your energy level? All the types of things that lead to biologically driven frailty. When we talk about the other types of frailty, things like deficit-driven frailty, it's a little bit different. What we see is that there are medical conditions, social vulnerability, in other words, if you live alone and you don't have somebody there to take care of you, malnutrition, cognition, depression, and functional decline. In other words, can you maintain your activities of daily living, those things like feed yourself, bathe yourself, and bathroom yourself. There are a number of different frail scores. And this one was the one that was used by Charlie Brown in this particular study is one of these longer frailty scoring guidelines that will allow you to, in about 10 to 15 minutes, identify whether or not somebody's frail. And what you can see from here is he took individuals who were having cardiac surgery, and those individuals that were not frail had a very low incidence of postoperative delirium, whereas those that were frail had a very high incidence of postoperative delirium, suggesting that there's something about frailty as well as cognitive impairment that's associated with the development of delirium. The problem with some of these tests is that they take a long time to administer, and there's a little bit of discrepancy about what it is that's going on. And so for us, we wanted something, once again, that was quick and dirty. We wanted a screening tool to see if we could identify people that had problems. So we spoke with our resident geriatrician, and if you want to talk about aging, always find your resident geriatricians because they've got plenty of information to share with you about what might work in a busy pre-admission testing center or on the wards preoperatively. And they suggested something very simple called the Frail Scale. It's a 5-point scale where it asks very simple things. It asks you whether or not you felt tired during the past couple of weeks. It asks you whether or not you have any difficulty walking upstairs or walking several hundred yards. It asks about how many illnesses you have and whether or not you've had 5% weight loss over the course of the last year. You'll notice here that there's no get up and go test, which requires that your patients actually stand up and walk about 15 yards. It also doesn't have any muscle testing. In other words, your ability to squeeze a dynamometer. Those are the types of things that will prevent you from being able to do frailties testing. So this is something that can very easily be done. It can be done on a survey form, and we actually have our older patients that are doing our studies perform that on an iPad, which makes it even easier to score. So it's a very simple scale. So the question becomes, if it's that simple, can it have much in the way of utility? And I would argue, yes. This is data from a study that's currently under review. And we looked at patients who were normal, who had cognitive impairment, either by the mini-cog or verbal fluency, those that were frail, and those that were both frail and had some degree of cognitive impairment. And what you can see over here on the left-hand side is those patients that neither had frailty or cognitive impairment had about a 10 to 15% prevalence of delirium. Cognitive impairment alone increased that prevalence to 30% or doubled it. Frailty was even higher at 40%. But if you were both frail and had cognitive impairment, the likelihood that you were going to develop delirium is 50%. Why is that important? I think we want to make sure that we're spending our dollars on patients that are at the greatest risk. And what this allows us to do is determine those individuals that are at the highest risk of developing postoperative delirium so we can use those medical options that we have to decrease their risk specifically for those high-risk patients. So I would like to leave this part with just saying that preoperative screening for cognitive impairment and frailty can and should be performed routinely in older surgical patients. It's not just me that's saying this. There are a number of organizations that are doing the same thing, and most geriatric guidelines would suggest that both be performed. I would argue, though, that that's not enough. We also need to screen for postoperative delirium, because if you don't screen for it, you might miss it. Much of the data says, very similar to cognitive screening, if you walk into a room and you're not looking for delirium, you're not going to find it. And in particular, the hypoactive delirium, which is that really great patient that the nurses love because they're laying in bed, they're not bothering anybody, they're not pushing the button, they're not demanding their food, is going to be missed unless you're screening for postoperative delirium. It's a very simple thing to do, and I think that it's important that you recognize how easy it is. You can do it either in the room with the patient there, or you can do it via systematic chart review. It's a little bit more difficult via systematic chart review because you have to go through every single note, but it most certainly can be done and is as validated as doing it in person. The requirements for delirium based upon the confusion assessment method is an acute change in mental status that can either be identified by your observation by a family member, caregiver, or primary care physician, because we see all these patients pre-op. All of our research assistants kind of know what they're like at baseline, and so when they go in to do the delirium screening, they have an idea. Their symptoms need to fluctuate over minutes or hours, and that can be identified through talking to the nursing staff or other caregivers about whether or not things have changed over the course of the day. What are the hallmarks is really inattention, and this inattention can be by patient history. They recognize that they're not able to pay attention to what they're doing. You can also do some digital recall or monthly years backwards to identify that. So both of those things need to be present, but in addition, there's got to be one of these other two. And the first one is an altered level of consciousness. Either they're hyper alert, which is hyperactive delirium. It's the kind of patient that you recognize who's pulling out their IVs, screaming, and in one case was telling me that I was trying to kill them. I most certainly was not. But there's the other version that we talked about earlier, and that's those that are drowsy, a little bit stuporous. But if they're actually in a coma, you can't diagnose postoperative delirium because you can't get any of these other things up here. So the coma I try to leave off whenever we're looking at our patients. But they can also have disorganized thinking, and that's that patient who's got this rambling and incoherent speech. And we see that a lot. It is amazing. You'll go in and you'll say, "How is your day?" And then we'll start talking about the restroom or something very similar that is completely unrelated. You're probably wondering, why bother? Why does it make a difference? When I was an intern, I can remember thinking about postoperative delirium as an event that should never occur. But the event that should never occur at that point in time was that I should never be called for it. Because if I was a really good intern, I would have written a Haldol order before I went to bed rather than being awoken by the nurse saying that the patient is screaming and yelling and is obviously delirious. But the reality is that delirium is a medical disorder and it can lead to very serious long-term outcomes. And so we need to pay attention to that. That's been associated with changes in your cognitive trajectory, in particular after CABG. What you can see here is this is a composite score of those individuals who did not develop delirium preoperatively, composite score a little bit lower of those who did develop a delirium postoperatively. So consistent with what we've seen earlier, impaired cognitive performance was associated with delirium. In all of these patients, there was some degree of cognitive decline in the couple of days to months after having a surgical procedure. That's not surprising. You're taking medications, you don't feel well, you've got an inflamed brain and an inflamed body. But what's more interesting is that in these individuals that develop postoperative delirium, their scores really went by in a couple of days after surgery. And if they were delirious for a longer period of time, it was even higher, even greater. But when you watch their long-term trajectories, they never quite got up to where it is that they were to start with. Now, we don't know whether or not that's because those individuals that were prone to the development of delirium were already on some form of cognitive decline and were just going to get to where they were anyway, or whether or not the development of delirium and their perioperative experience it simply increased the time frame by which that occurred. But there's a lot of growing evidence to show that delirium is associated with longer-term cognitive decline, something that we don't want to have happen because we'd like to have our elders out of acute care settings and living in the community. It's also associated with mortality. This is a study that looked at post-operative neurocognitive disorders, including both delirium and POCD, and what they found is that if patients did not have delirium, when you just looked at delirium versus no delirium, the likelihood that they were going to be dead at 100 days was, about 0.8, whereas it was quite a bit higher at 0.2 for those individuals who had delirium. So delirium is not just a transient phenomena. That transient phenomena can recur over the course of days to weeks to months. Sometimes it will occur in individuals who are even at home, and it's associated not only with longer-term cognitive decline, but an increased mortality risk. The question we are asking ourselves now, though, are, what can we do about it? These are a couple of controlled study trials, the protocols for them that are ongoing to identify whether or not multimodal rehabilitation can increase or improve the outcomes for these older surgical patients. And we don't have the results of these trials yet, and most of the trials performed to date are a little bit mixed. This is a study that looked at home-based prehabilitation in older surgical patients that was done at the BI Deaconess Medical Center. And what you can see is they were able to enroll 61 patients, but 37 of the patients declined. In other words, it's really difficult to get these patients to enroll in these studies. And many times they would say they lacked computer access, but these were individuals that the group had been able to identify via computer in order to enroll them. And they thought that it was just that they didn't want to participate. Most interestingly, of the 61 patients that enrolled, 5 of the 29 in the prehab group actually completed testing. There's a hint here that there was these are exactly opposite. This one should be the prehabilitation group actually did better than those that did not have prehabilitation, but that was not statistically significant. It just shows how difficult it is to enroll somebody in some form of a cognitive or physical rehabilitation program prior to a surgical procedure without documented efficacy in doing so, simply because it's very difficult for our older patients to do. This is a meta-analysis of a larger number of studies, most of which were negative. There's 3 here that are positive, that hint at the idea that multimodal interventions can actually be valuable for our patient population. So we need to think about them as we move forward so that we can identify patients at risk and maybe decrease the risk of developing delirium and the subsequent morbidity that goes along with it. I'm frequently asked, what can you as an anesthesiologist do? I think some of the things are that you can preoperatively screen them for frailty and cognitive impairment, as well as testing for delirium postoperatively. So if they have delirium, you can get the help of a geriatrician to decrease its severity and length. Most people want to know about using general versus regional anesthesia, and it makes sense. I mean, general anesthesia is coma. Why wouldn't it increase the risk of postoperative delirium? Most of the studies to date, and this is a meta-analysis that was recently published, would suggest that there's no difference in regional versus general anesthesia. And I don't know whether or not that's necessarily the case, because regional anesthetic where I work usually involves a resident, a propofol infusion, an oral airway, and a jaw thrust. And when you walk in to relieve them in the evening and you say, oh, why so much propofol? They say, oh, it's just a MAC. So maybe if we really were doing just sedation, we might see something a little bit different, or if we didn't do sedation at all, but to date, the data doesn't support it. A lot of people have been interested in processed EEG and whether or not it can be used to decrease the risk of postoperative delirium. The idea being that you put a target EEG value where you want your patient to be that would be in a clinically relevant range, such that you're avoiding things like burst suppression. And up until last year, most of the data would suggest that there is some benefit of EEG monitoring to reduce the depth of anesthesia and reduce the incidence of postoperative delirium. That was until the ENGAGE study came out in JAMA in 2019. This was a study that was done by Michael Avedon and a large group of individuals. And what they did is they randomized patients to normal anesthetic or BIS-guided anesthetic. And what they found is that in those that had the normal anesthetic, the delirium value was no different than it was in those that had BIS-guided general anesthesia. That meta-analysis was redone, and sure enough, the little square here crosses over the one, such that it doesn't seem at the current point in time that there is a benefit of BIS-guided anesthesia. Now, I know that you've got people in your group that actually look at EEG with regards to anesthesia, so I don't want to scare you into think that this information is absolutely over or that it's not of value, because I think that it actually might be. This was a mediation analysis looking at not only those individuals and their depth of anesthesia or the group that they were assigned to, but rather those that had delirium with preoperative abnormal cognition and those that had delirium without preoperative abnormal cognition. And what you can see is that in the abnormal cognition group, the incidence was about 35%. In those without delirium or with delirium but normal cognition, it was about 18%. So the direct effect of cognitive impairment based upon their mediation analysis was this number here, somewhere between 12.1 and 16.5% of the effect of delirium was thought to be due to the presence of preoperative cognitive impairment. An interesting study. But the story gets a little bit more interesting. This is a study that was done by Jackie Liam, who also used EEG and looked at the incidence of delirium and found absolutely no difference between the two groups. They did a really good job. They were able to alter or decrease the minutes in EEG suppression or time in EEG suppression in the intervention group relative to the standard care group. But if you read through this article very carefully, they found that the effect of the intervention, in other words, BIS-guided anesthesia on EEG suppression, differed for those with and without preoperative cognitive impairment. In other words, it was much harder to get those patients with cognitive impairment out of burst suppression. So there's something about that vulnerable brain that's obvious and present. This is another study. This time they're looking at neural correlates of postoperative delirium and neural connectivity. And what they found is that there's a lot of local slow wave activity over the frontal cortex, but that seemed to be insufficient to cause delirium postoperatively. But rather that delirium was associated with an increase in slow wave activity involving the occipital and parietal and frontal cortex with an accompanying breakdown in functional connectivity. In other words, the pre to post change here in these neural correlates of slow wave activity and fast wave activity were very different in the no delirium group when compared to the delirium group. Just another way for us to look into the brain to attempt to identify what it is that's going on in this aged brain that makes it more susceptible to the development of postoperative delirium. The other thing I just wanted to bring up is there's a lot of studies that have talked about dexmedetomidine. I think most of you probably recognize that. There's been a number of trials that have demonstrated that it seems to decrease the risk of postoperative delirium. I don't know whether or not that's a direct effect of the drug itself versus whether or not it's due to sleep. And you know, if you're going to do one meta-analysis in 1 year and it's by one journal, you might as well do the same meta-analysis in another year by a different journal. I'm just trying to share with you my concern about meta-analyses and the fact that anyone can do them. It's good that these two were the same, but I don't know that we need two of them on the same topic in the same year. Here's a systematic review and meta-analysis examining the impact of sleep disturbances on postoperative delirium. It justifies the idea or one of the concepts by which dexmedetomidine may work. And there's a lot of evidence to show that a sleep disturbance prior to the development of delirium is associated with the risk of developing delirium. So you want to make sure that your patients are sleeping well. Many people have used things like geriatric care units or the hospital elder life program developed by Shitter and Inouye. It involves some very interesting things that are simple and easy to do and basically represent good medical care. They orient their patients daily. They provide them cognitive stimulation. They get them up and out of bed. They provide them with visual aids and hearing aids. I can't imagine not having my glasses on and not being a little disturbed by that. They make sure that they're eating and that they're drinking, that they have non-pharmacologic sleep enhancements, nursing interventions, interdisciplinary rounds, provider education, referral for transitions to home, and targeted geriatric consultation. In other words, just really good medicine for these older surgical patients. Because delirium is prevented, and that these multi-component non-pharmacologic interventions that I just shared with you have been shown time and time again to decrease the incidence of delirium postoperatively in our vulnerable surgical patients. So something easy to do. It takes a lot of effort in order to make it happen, but it's really not rocket science. It's good medical care. We're in the process of trying to move on towards mechanisms. How does this happen? Can we take liquid biopsies of your plasma, your exosomes, or can we look into your brain through PET and other alternatives? This is just a first run through where we did a very large panel using O-link technology, which allows you to use a polymerase chain reaction to increase your ability to count those proteins that are not prevalent at high concentrations. In other words, you can go all the way down to femtomolar concentrations. And so far, we found a large number of proteins that are either present preoperatively, postoperatively, or changed between the two. What's most interesting is there's no preoperative proteins where there's been any differential expression between the pre and the change, the value and the change between pre and post-op. There have been a number of post-operative changes. All of those have been high. But when you look at these differential changes, often they're going to be those types of proteins that actually are down here towards the bottom that you have, they went from a higher value to a lower value. So there's something going on with the inflammatory mechanisms with regards to the development of postoperative delirium. And hopefully eventually we can either develop a tool that will allow us to predict those that are likely to have preoperative delirium, perhaps a diagnostic tool, and hopefully more likely than not, ultimately develop an understanding of the mechanisms by which postoperative delirium works so that we can come up with better treatment modalities to both prevent and treat it in the future. So with that, I'd just like to say that I think cognitive impairment and frailty are common in older surgical patients. I think we all know that. They're risk factors for delirium and should be screened for and preoperatively to allow for optimization of their perioperative management. I told you I'd tell a story about my grandfather close to the end. This is my grandmother and my grandfather. My grandmother lived a life of Alzheimer's disease from the age of 70 at an end stage until her death at the age of 96. He cared for her the entirety of this time. And when I talked to him about the things I was going to study as a very young physician and that I was going to look at cognition in rodents, his words were, for me, were very clear. Do what you can, because these types of cognitive impairment are horrible, not only for the patient who has them, but the need for somebody else to watch someone they love lead toward the abyss of life where they don't even remember them is extremely painful. This man, this guy right here, is interesting because we're talking about a pandemic now. Well, he was 2 years old during the Spanish flu and nearly died of pneumonia. He's still living at 104. He does live in a care facility, but he's had a very great and wonderful life. I would be remiss by not mentioning my mentor, Greg Crosby, and Mark Baxter, who've been with me since the beginning of my career, as well as the remainder of the research team. So with that, I think I'll go ahead and stop. And if you have any questions, I'm more than willing to answer them.
Well, Deb, I want to thank you for a tremendous seminar. We appreciate it so much. I'm going to ask you a couple of the questions that have come in over the chat and the Q&A that maybe you can respond to. We had two questions that related to the use of the mini tools in relation to how they might have been validated against gold standard tools, particularly the mini-cog, and then with respect to frailty analysis, whether when you ask a person something like, you know, how well you did climb stairs, well, that assumes, of course, the person has tried to climb some stairs. So we want expedience, but we also want validity. How has your group approached that?
Yeah, so probably a little bit different than you might like. We were not trying to diagnose cognitive impairment. That was not the key. We were trying to identify those people who would be at risk for delirium. So when most of these brief screening tools are validated, quote unquote, they're compared to the mini mental status exam. They're usually not compared to a comprehensive neuropsychiatric psychological evaluation. We've accepted that as a limitation because the goal is not to diagnose cognitive impairment, it's to identify those patients that are at risk for adverse outcomes. And because it seems to work reasonably well for that, we've been using it. And that's why I said right from the beginning, I don't think that there's any tool that's better than any other. They all look at different regions of the brain and different types of memory. More recently, I have to admit, we have moved on to the MoCA, which is a little bit more of a comprehensive cognitive screen. However, what I can tell you, we've only enrolled 70 patients into the study that involves MoCA. Our study was shut a little bit early because of COVID. And what we found is that the only things that are correlating with delirium in that happen to be the clock drawing test, the memory test, and the verbal fluency, which asked them to name words starting with the letter F. So we might have gotten lucky when we chose the test that we did, but they have not been validated against comprehensive neuropsychometric testing. With regards to the Frail scale, you're absolutely right. It's another one of those things where you are looking at the pluses and minuses of each thing. There could be people that have not been climbing stairs, but you can usually get that out of them by asking them right off if they do, and then you do allow them to use a surrogate, could you? So you're probably going to miss some people there. The benefit is that you're not spending the 6 minutes with a get up and go test, and some people won't even try to do that. You're decreasing the likelihood of needing to do a dynamometer with regards to another way to test motor strength. So it works well in identifying those patients at risk. It's probably going to miss some of those individuals that are in denial. Did that answer the question?
Yes, thank you so much. I'm going to move on to another question which relates to the very striking data you presented showing mortality and then delirium and frailty and the apparent interaction of the two. And the question is, are the effects of delirium and frailty truly independent, or are you maybe assessing a common underlying set of factors that are then contributing to mortality?
Yeah, that is a great question. And I think that you're probably right. The frailty screening allows you to identify those patients that are at risk. They're pretty frail if they get to the point that they're labeled as frail. The score needs to be 2 or less, which means they really can't do a whole heck of a lot by themselves. What we think happens based upon who we see bringing these patients into the hospital is those frail individuals are able to live alone and quote unquote independently because they're living with a very capable spouse or oftentimes a daughter who's taking care of them. They probably could not live independently by themselves alone. So I do think that there's something more that's going on both with the frail and cognitively impaired patients that we probably don't understand that well, and that they probably are all in some bucket that lead to the likelihood of postoperative delirium. I think though that delirium is probably a separate entity from frailty. Those things that make them frail probably predispose and might have something to do with the mechanisms involved, but I don't think we know that yet.
Okay, before people kind of go off to their morning responsibilities, I wonder if we could get Deb's list of what it is we should be doing with folks who we perceive as possibly at risk in a preoperative clinic to try to position them for their best surgical outcome. That is, given the evidence of today, what can you recommend in general terms about their preoperative evaluation, their intra and postoperative management? What would you do for an elderly?
So what we do in our institution is if they screen positive for frailty or cognitive impairment, that means they get an automatic geriatric consultation preoperatively. There are a lot of very simple things that geriatricians do, such as modify their drugs so there are fewer anticholinergic effects, make sure that their electrolytes are normal, try to get them into some sorts of rehabilitation programs, and then they follow them both when they arrive at the hospital and postoperatively, helping the team to manage both their medication management, their pain management, their electrolytes, because very small things can throw an older person into postoperative delirium. If you don't have a geriatric consultation service, sometimes if they've got cognitive impairment, they can see a neuropsychologist to see whether or not they have severe problems. In our setting, they just simply do not want to do that. So what we have a tendency to do is make sure that we are having somebody do delirium screening postoperatively. It's really hard to teach spine surgeons in particular to do delirium screening. But I think that it's time for everybody that's on those medical and surgical wards to actually be doing so. And then if you find somebody who's got delirium, if you don't have a geriatrician around, the psychiatrists are very good and very tuned into identifying the causes of delirium, because the most important thing to do is prevent it before it's out of the bucket. But once it is, you want to make sure and treat those things such as urinary tract infections, pneumonia, etc., before they get much worse.
Just to follow up on that a bit, you mentioned the concept of prehabilitation programs, which have become quite popular. We often think of these related to physical prehabilitation and doing better after, for example, a joint replacement surgery. Could you briefly review whatever evidence might exist for cognitive prehabilitation, where you think that field is going to lead?
Yeah, I don't know the answer to that. And I've actually thought about entering that space, but it's a very difficult thing to do because you're relying on the patients to actually follow up. I did show you one study where they were required to do cognitive prehabilitation, and it looked like they probably got a little bit better, but such a small percentage of the individuals were actually willing to participate. I do have a very dear friend and colleague who's a neuropsychologist, and she's been working on something very similar, but getting them to actually participate in the cognitive prehabilitation has been very difficult. Probably partially because they're very stressed out, they're going to have a surgical procedure, they've got a lot of other things going on in their world at that point in time, and that's not really where they want to spend their time. I don't know whether or not you can cognitively prehabilitate someone enough to where they're not going to have subsequent cognitive decline, but there is a large body of evidence to suggest that higher educational attainment is associated with a decreased risk of cognitive decline and delirium, which makes it very intriguing to think that you might be able to train your brain a little bit before surgery and anesthesia.
I think we have time for just another question or two, and I think I've probably gone through the list that's come in. I've got to ask, because our journals are filled with these papers, including the one that you have a strong leadership role in. Do anesthetics have anything to do with this, or is the problem really, a surgical trauma and a moving of a patient to an unfamiliar environment with all kinds of different changes? Does it matter if we give them ketamine or propofol, or is that a little vainglorious?
Well, when I was younger, I would have said propofol over volatile anesthetics, because if you're a Fisher 344 rat, there's data that we published and data that's been replicated by other groups to suggest that a propofol anesthetic is not associated with longer-term cognitive impairment, whereas the volatile anesthetics are. But when you look at the human data, there's just nothing to suggest that general versus regional anesthesia makes a big difference. So my bandwagon is kind of moved over a little bit now, and I've moved a little bit more toward the side of it's probably partially, at least, the surgical procedure. But when I look at these EEG studies and you see that burst suppression and connectivity seem to make a difference, that's the area that we as anesthesiologists really own. And that's probably the direction that research really needs to head, so that we can identify things that we might be able to modify for that older patient who's in EEG burst suppression. Would a nitrous narcotic anesthesia be better for them? I mean, my gosh, could you imagine bringing that back? I can't imagine it would work. But when you talk about things like ketamine, it's not really been shown. And I don't know whether or not, I haven't really seen data that I know of that would say that this disconnect, this cortical disconnect, is more common with a volatile versus an intravenous anesthetic. So I wish I could answer that question. I spent a lot of days, months, years anesthetizing rodents, but it doesn't right now look like it's all that much associated, at least at a molecular level. and probably that the surgical procedure in combination with some anesthetic effects, if they exist, is the more likely cause.
Well, I think you have, again, given us a tremendous lecture this morning, a great deal to think about. I thank you so much for joining us. And again, apologies that plans were upset, though no one has been able to grapple with the circumstances very well. Thank you so much for agreeing to meet with too long a list of folks who we let it go. We let it go a little further than we should, perhaps, but you're a popular person. And I think there are going to be some tremendous conversations. I hope that we can have you out to Stanford sometime soon to see you in the flesh, so to speak.
Well, thanks, David. It's really been a wonderful honor and privilege to be here. I, too, am sorry that I can't be in sunny, beautiful California, where there seems to never be high humidity. But I look forward to seeing you soon.
And thank you for everyone who attended the seminar. Goodbye.